Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, I am talking with Simon Puparelia, who is finishing up year 3 of the Bachelor's Paramedic program. Simon, welcome back.
Hello, Aebhric. Good to be back.
You're just after getting back from Kibosho, and we'll talk about that in a second. But tell us about yourself. Who are you? What you're doing? Why are you with the college?
Okay, I am in my third year. As you just said, I'm finishing up that third year now. It's taken time over COVID to get to this point, but I'm very happy that we are here and now in the final stretch of the course towards the bachelor's. So very happy about that. We talked previously about my experience on the program, and as we've progressed through the years, and now in the third year, of course, it's a lot more autonomous, and the focus is on studying independently and getting through my coursework and the reports, dissertation. But happy to do that, and happy to be finishing the program. This is obviously a side. I'm doing it part-time. On the side, I'm also working. I work in healthcare marketing. And I do that role in Europe and around the world. So pretty much have a full-time job on to fit the studies around as well. So all good to be here, and thanks for having me again on the podcast.
No bother at all. Plus, you were fundamental in getting the website upgraded for the Wilderness Medical Society.
Yes, that's right. That was more than the website. I did a small project with them to look at their new brand and their new brand identity. They'd already done quite a lot of work in what they meant, the WMS meant to the world, and they needed a little bit of help just to get it going and get the branding up and running. So a small little project that we did earlier in the year to get that going, and I'm happy to see that all come to fruition, and it looks fantastic. So hopefully that will take them into new directions, attract a new set of wilderness keen medics and beyond, and hopefully it will be a fresh identity for them to take them into the future.
Definitely, it is a vast improvement. So well done on that. So you have been to KCMC twice, is it?
Yes, in my second year I did 2 stints at KCMC. KCMC being the referral hospital in Moshi, Tanzania, and that's the 800-bed hospital where I know that we send our first year, second year. So I was there in the capacity of being a first-year student, and I did 2 stints there to do my hours, alongside some of the other students from Quorum as well at the same time. And the 2 stints were fantastic. It's a huge operation in the hospital, but I focused my time in the emergency medicine department, the ER of KCMC, and I spent most of my time there.
So we have set up KCMC as a Kilimanjaro Christian Medical Center as a great place to start out on the bachelor's degree program. So if you're an EMT level or paramedic student, year 1, it's a great teaching hospital because you're always under the tutelage of Dr. Francis and his lads and ladies there that can mentor you. But for those of you who are going to year 3, those of you who would want more advanced clinical experience, we've set up the Kibosho District Hospital. And I stumbled onto this ages ago when one of my trips to KCMC, somebody was like, "Oh, you like the remote medicine, austere medicine? I got a place for you." And so we hopped in a cab, and Johnny took us all the way up. It's 14 kilometers up the hill. Up Mount Kilimanjaro, and it's just a different world. It's cooler. It's funnily enough more jungly, more monkeys are swinging from the trees, quite literally, and it's a perfect location for those who are wanting advanced experience and autonomous. So what difference did you see, Simon, between your stints at KCMC and then going up the hill to Kibosho?
Yeah, you're right. It doesn't sound like a far 14 kilometers up the hill, but it is a world away. Absolutely. So you rise up on a tarmac road, and then the last say 5 kilometers is on a dirt track, right? And you finally get to the hospital, and you wonder, why is this, and where on earth did this hospital come from? And to be based here, right? Why is it not on the road? But there's a lot of history there. It goes back to I think the 30s or the 40s, where the hospital started as a simple dispensary, and it's grown from there. And now it is a 200-bed hospital. It serves a wide area of about 20,000 people. And there's about 100 plus patients every day, including the weekends, coming in for outpatient consultation, on top of the deliveries. So a huge maternal focus, and there's at least 5 to 10 deliveries per day. So if that's your focus, then you will be inundated with babies, absolutely. But so a very busy hospital, very busy environment, and in the middle of nowhere, really, right? So even though it's only 15 kilometers up from Moshi. But as you say, very different experience. And the reason is, and I can do a kind of quick comparison here, or a direct comparison between KCMC, the referral hospital down on the bottom of the hill, and Kibosho, because I've worked in both the EMDs, the emergency medical departments of both. Now, whereas KCMC is obviously the point of entry for the hospital and all of the patients coming in, critical or otherwise. The process is on, of course, stabilization, assessing that patient, and then moving them off to wherever they need to go in the hospital infrastructure. And the disposition of that patient is then very clear and quite quick. And so you are dealing with a patient where, at best, because there's so much volume of patients coming through KCMC, and you've got opportunities to send them to the different departments, specialist departments, you're really seeing the patient for maybe an hour or half an hour, doing your assessment, doing the first line treatment, and then that patient is off to either minor surgery or another department or the wards. Now, that story is very different in Kibosho. You will be with a patient from the minute that they come in the door through all of the assessment and initial treatment, and then looking after that patient until they're stable. So the difference is that in the EMD department in Kibosho, they have roughly about 15 to 20 emergency ward beds split between male, female, and pediatrics. And the focus is on stabilizing that patient there in the EMD department for as long as it takes until they're ready to either be released or referred down the mountain, or they go into one of the wards. So this is where the whole concept of prolonged field care, albeit inside a resource-restricted environment, that's really coming into its own. And that is where the skill level of seeing that patient and treating that patient for the longer term comes into play as well. So a very, I wouldn't say different skill set, but a different mindset, that you're not just dealing with suddenly medical and trauma problems coming in the door, assess, and work as efficiently as possible. You're now dealing with a patient who you're going to stabilize for the longest period of time. And in that environment, I was working in that EMD every single day. So I would see that patient every single day that I would be doing my shift. And there comes a point where after 4 or 5 days working in the EMD, you now know all the patients who are there, right? Whether or not they're in the ward or they are coming back for referral treatment, etc. You know everyone. You know all the patients that you're treating for, and that's a unique experience and very different from KCMC.
So I like that location because it is so remote that the 60 medical students, the expat medical students that are down at KCMC, they just can't be bothered to go all the way up and be that far away from discotheques and pubs and everything else, that they all got, leave the hospital at noon and go out and do their they go up to the waterfall or something. They don't really stay in the hospital. At Kibosho, if you see 1 or 2 medical students there, they're motivated. They're there to learn. So our students are same as that. They're there to learn, and they're hands-on, there for 16 hours at a time, and you're able to do everything. So it's a fantastic place for the soft medic is kind of what I had in mind. I've sent several soft medics there from several different countries to get experience. People have come to me. The last one is an 18 Delta from Stuttgart, and he's like, I just need some excellent austere medicine hands-on, And then the only place I would want to send him was Kibosho, and it is a fantastic place to practice all areas of medicine. Did you get to go into operating theater as well as other wards?
I spent time in the minor surgery because we had so many cases to deal with that we did. I was there and assisting and also treating directly the patients in the minor surgery area. So my focus was there. Didn't quite make it into the theatre, but the patients, we were looking after the patients as they came out for recovery, and they come straight back into the EMD, which is right next door, and then we look after them for their recovery period, and then for, of course, the prolonged care for the next few days until they're fully stable. So not so much on the surgery side, which I knew that I wasn't going to get on so much hands-on time, but absolutely hands-on in minor surgery.
The minor surgery and then and moving him from like EMD or minor surgery into the medical wards whilst they convalesce is a fantastic experience. I remember seeing one of the docs get 3-liter bottles, tie them together, put it over the railing of the foot of the bed, and then tie that onto the leg for a midshaft femur traction, and he would keep that patient there for until healed. So that is not science by any means, but he's estimating was it 10% of the body weight that you needed to pull traction on a midshaft femur, and that's the only thing they had was filled 3-liter water bottles.
Yeah, so there's a lot of improvising going on with the equipment that is there. They have the equipment, they have the staff who are knowledgeable about that equipment, no problem there, and who will guide you if you don't understand the tool or any of the equipment to use. But it doesn't go around everyone. There's not enough of anything, and so you have to improvise with either what you've got, or you have to share or somehow distribute the resources that you have. It is true resource management over the longer period, and especially when either in that convalescent period or prolonged care of any of the patients who are sitting in the ICU or the male or the female ward. Where's that resources? What are you going to do with it? Where are you going to put it? Who's best in need? How do you divide that up? And that's everything from oxygen concentrators to the even the drip stands. You have to, if you've run out of drip stands, you have to find alternative, right? So simple things like that. It's hands-on in the best sense of the word, right? In terms of I think the drip stand is a great example. Find a solution, find something that's going to help, right? There is limited amount of people around. You're there with the nurse, the doctor's tied up. Find a solution, right? Make it work. So lots of moments like that happen through the day as well.
The last time I was there, I was really impressed because I saw a plastic lawn chair, and some yoke had taken that chair and put the wheelchair wheels on it, and they had a wheelchair made out of a plastic lawn chair. I'm not sure if that was still there when you saw that.
Haven't seen this one, but yes, there's plenty examples of where they've improvised and the team have used the equipment that they've got and they've used it to the best capabilities. And you learn hands-on skills like this, which are just invaluable. And what you can do with one piece of gauze to open it up, tie it in so many knots. Yeah, it's just brilliant. A brilliant experience of learning how to utilize everything to its capacity. Nothing is unsafe. Everything is to international standard in terms of giving drugs, medications, checking medications, sterility, and so on. Nothing like that. The improvisation comes from elements like this, and in making patients comfortable, in applying traction, in using the resources as far as possible, right? So that's where you have to have an open mind and think, okay, I'm looking after this patient for the longer term. There's 3 more in the corridor. What are we going to do? Right? We can't use every resource on this patient. Who needs what? Think ahead. Think what the patient might need. Think how stable they are, and work with what you have.
What impresses me about KCMC at Kibosho is they're clean. Like they're spotless. The windows won't have a glass in it. It's just a hole in the wall, this square that's been plastered in, and it's clean. I don't remember seeing any corner with dust bunnies or anything. And just that, so that the level of standard that these two hospitals have is spectacular. It's the best that they could do whilst following evidence-based medicine, whilst having a limited supply of equipment. It's a fantastic location for improvisation.
Yeah, we have a massive team of cleaners and medical attendants who keep the place spotless. And even I commented to one of the sisters, and I said, it's raining outside, and you've got white trainers on, and of course your white uniform. How do you keep it so clean? And she told me that's a must. We must keep it clean. If we lose the focus on keeping my white trainers clean, then what does that mean for patient care? So brilliant. It was just the immediate response I got back from the team. So absolutely, you will find things. The machinery is older, the equipment, monitors, and so on are older, but not unclean and not unsafe, right? So those things are not a problem.
So during this last deployment, what were some of the more serious cases that you saw?
There is a lot of focus on hypertension, patients with hypertension, and patients with complications related to diabetes. And I think some of the more memorable cases and those that took time to treat were those with complications related to diabetes. So diabetic foot ulcers, ulcers from bed sores, which are also infected. These are the ones which are mostly in an older population. They are in and out of the ER. They are coming in some cases daily for wound management. These are wounds which are so heavily infected that we are aggressively treating with antibiotics, with cleaning, with removal of necrotic tissue, with then rebandaging, even exploratory incisions to find a source of infection. So the complications related to diabetes is huge and a big, massive problem for this area. Let alone patients with hypertension and complications related to this, including stroke. So patients who are most serious, this is less of trauma from road traffic accidents in this area, because we barely have a road to lead to the place. But you're going to see patients who need medical complications and medical care and a good, thorough history taking, a good understanding of what led to this situation, and including why they have stopped taking their medication, and what they've done about that, right? Now, many of these things are related to cost. Many of these things are related to superstition, family input, family matters. So you see the full human condition appear in front of you over the days that you're there. And that is, I would say, it's a strange word to say, but it's a luxury for a medic to have the ability to see a patient, understand a patient for that period of time, right, in this prolonged care. Some of those patients are coming in every day to the EMD, and I see them for just 1 hour, 2 hours of treatment, like redressing, and then we see them again the next day. And some are then admitted, like in the case of a stroke patient, and we see them for the next 5, 6, 7 days. And in that period, you explore everything. You see the family coming in, you see the struggle with either understanding what is happening, understanding the condition that they're in, or confusion of what medication should be taken and when and how and why, or simply that they can't afford it, and the complications of that. And you see the strain on the family, you see the interaction between the patient and the family, what they can do about it, and that's all there in front of you and playing out as you go through your time on the ward.
So it's a great place for medical issues and not so much on trauma.
Yeah. Oh, having said that, when it rains, we get motorbike accidents coming in, 2 apiece. So it's a muddy, a steep road. It's dark. And any of the accidents that we get, if it's been raining, then the next day you're going to see some particularly motorbike related trauma.
But to be fair, if you're looking at practicing prolonged field care skills, you're going to want uh, the medical casualties, and the trauma. It's important as well, and of course you can go down to the A&E department with Dr. Francis at KCMC and get trauma there. What kind of daily trauma were you seeing at KCMC?
Yeah, in KCMC we had many road traffic accident related trauma. We had violence and domestic violence trauma as well. And then at the weekends, you would have trauma related to, same again, violence or related to the environment that they're in and going out on a night out, and it's low level violence or it's low level trauma, right? But in most cases, the biggest trauma was probably road traffic related, right, in KCMC, the ones that I saw,
Right.
and burns as well. So plenty burns, both adult and pediatric as well. Haven't seen so much of that. It's a smaller population, Kibosho. And we saw the trauma that we did see was mostly related to motorbike accidents going up and down the mountain.
And would they then transfer down to KCMC if they were serious enough?
For the trauma, not so much, because I, in the time that I was there, hadn't seen it. Although, yes, they are transferred down once they're stable, if it's warranted and if they can afford the treatment that comes with the transfer, or they may be sponsored patients so that they are able to be referred. If not, then they stay in the emergency room department in the emergency ward until they're stable enough and or can afford the treatment to continue in Kibosho. So a mix kind of disposition for those patients. Very different from KCMC, where you've kind of got everything there. The treatment is a little bit faster, but still you still come up against the same barriers of cost, treatment, or sponsorship at KCMC. So that the end situation is the same for the patient for the next stage of their treatment. We did refer medical cases down to KCMC. I took one neonate down the mountain with breathing difficulties, suspected pneumonia, and this patient was with us for about 2 days, aggressive treatment before we then decided to refer down to KCMC. We have an ambulance at Kibosho, and I took the patient down in the back of the ambulance with our expert driver who can navigate his way down the side of that mountain. There's a few times you get a little bit airborne as you go over the bumps, but otherwise it's a good ride down the mountain, safe ride down to KCMC. And of course we phone ahead to KCMC so they know to expect us, and we know where we're going if we need a pediatrician, for example, in this case. So we were an expected case, and when we arrive, we are then straight into the EMD. And they see me arriving. And so that was to some quite bemused faces, because I knew the team there at KCMC. They were not expecting to see me walk through the door with a patient, but that was great.
Brilliant.
To catch up with that team. But yes, so there is a transfer. That transfer, it takes about 20-25 minutes to get down the mountain.
On good weather anyway.
Yeah, under lights and sirens. So we did that. And that happens maybe twice or 3 times per week to do that when the patient is being referred.
So another advantage with Kibosho is with fewer medical students, you're not in queue to try to get hands-on. They don't know what to do with you. Like you're not a medical student, you're not a doctor, you're a paramedic. They don't know what to make of that, and therefore you have to kind of introduce yourself, and they get used to the fact that you're very much hands-on. So a med student isn't. The med student's going to stay back and just get their signature they need at the end of the shift. But our lads are definitely knuckle draggers coming in and getting hands-on.
Yeah, I think, even the terminology is a little bit lost on both the medical staff, because they don't have the experience of that role, right, amongst them, and definitely on the patients who don't really appreciate the the role or the skill level or what you bring, or where your limitations are, more often or not. So in most cases, you are always referring to the doctor for the decision on medication, for the disposition, for what we're going to do with this patient. And there's, of course, a limit to what we do as the paramedic. You don't change the scope because you're there. You work within the scope that we have. But yet it is still confused story. So there's a lot of explanation about what the paramedic can do. It's probably a bit easier to work in the EMD because we are hands-on anyway. We know what we're doing. We are very much welcome in the emergency situations as well. We had plenty of those where there was resuscitation taking place, and you naturally lead the resuscitation effort as well. So in those cases where it's quick emergency medicine and it's resuscitation particularly, then yes, that makes a lot of sense and your value is seen immediately. Less so when it's on the ward and you are managing those patients in the prolonged sense, but probably more of the questions I'm asking the doctor than they're asking me to help on something. So it's a learning curve in both ways. But yes, it takes time. I was there at this stint for only a few weeks, but by the end of that, I think they helped them clarify the role or the value I could bring to the EMD department, and therefore other paramedics who work in that environment would bring as well. I would say the focus is really on the paramedic in the EMD department, unless you want to specialize in a certain area. And even if you do want to specialize, you can do 1 or 2 days in maternity, for example. Go and deliver babies in the middle of the night, no problem. That option is available for you. They will welcome the help. And in fact, they actually ask for the help in some cases when they're short of staff to the other departments. But in most cases, you'll spend the time in EMD. You'll be a valuable addition to the team. And your skills will be required, used, utilized, and then valued there.
So it sounds to me like the best option for a remote medic or a soft medic would be to come to Tanzania and spend perhaps 1 week at KCMC with Dr. Francis to get their trauma, and then the next 2 to 3 weeks, 4 weeks in Kibosho to get their prolonged field care experience, to get the medical experience, to get the experience that they really need as austere medicine providers.
I would say so, yes. The difference is, though, that you still need to build up a good rapport and chemistry with your team, right? The nurses and the doctors of the department. And I found it beneficial to stay. That's why I stayed in the one department for the whole time. And by the time that I had worked then 3-4 days in a row, I'd seen the rotation of all of the staff, and they all knew me, and they were now on their second duty, and then I'm still there, and so they're familiar with what I can do, and therefore they invite you in to help. They invite you in to take care of the patient or to be hands-on, right, completely. And so that's very valuable. If you do too short a time in either place, then the restriction is that you might not have time to build up that personal relationship with the team around you. And the team dynamic is super important here. And it adds a lot of fun. There's many times where we are quiet in the department, there is no patients there, and we have the music playing out of somebody's phone, while we're doing some of the administration or cleaning. It is a healthy, fun, collaborative environment, and the teamwork aspect is essential for managing the stress factor, for managing the fact that they're working long hours, they haven't stopped for a break, right? Or they have to cover another shift, and that teamwork is fundamental. And you are invited to be part of that team the minute you get there, and you're instantly part of the team, and you feel like that as well, which is great. So I'd say the more time you can spend dedicated to one of the locations, just from a team dynamic point of view, probably helps you get more hands-on eventually with the patients that you want to treat.
So at least fortnight is a minimum, you think?
At least, yes, 10 days, a week to 10 days. If you're going to split it up between the two, yeah, that would make sense, minimum.
So tell us where you stayed. How was because there's no restaurants up there. There's no hotels. There's nothing. So where did they put you up?
The accommodation is on site, so there is a kind of a bed and breakfast or a full meal service, if you like, with the sisters who look after the residences there. So there is accommodation. It is simple accommodation, but you have your own room, you have an ensuite if you're lucky, or you have a shared bathroom with 2, 3 people. All of the international guests stay in the same location, very similar to the KCMC setup. And the best thing is that then the meals are provided for you, and one of the sisters will bring the food or will come to cook at your location at the apartment, which is on site. It's just 5 minute walk in the same compound, and they will provide for your food. And actually, I probably ate better in Kibosho than I did in KCMC, because you're tired in KCMC, you've done a long shift, and then you've still got to go and find food, right?
Yeah.
And it's easy to not eat well. Whereas here, you can take a break no matter when it is, and the food is there prepared for you. So I really appreciate that, having that service available. You pay for that, so that's a daily charge for the international guests. But that was invaluable because it allowed me to focus on working all the days that I wanted to work in the EMD. And then when it came to around dinner time, the minute I could get a break, then that's it, take a break, walk up to the apartment, and there was the meal on the table, which was fantastic. So that's a luxury for us that you have to pay for, but it's a luxury for us being there and working on site.
Plus, right out front, the front gate is a little thatched market. Did you go there? You can get wine, you can get chocolates. You know, the two mainstays you need in one of these things. But you can top up your phone. Did you go and kind of wander around that area?
Yeah, there's a few little shops just outside the gates. They mostly cater for the visitors or the patients, and as well as the staff who are there. But there's a little spot with a few beers and a surprisingly amazing sound system out the back. So if you want a little time off, then yes, you have the option as well. And if you get friendly with some of the doctors as well, they will show you some of the spots nearby. So you're not completely in the wilderness. There is a little option, but yes, don't expect nightclubs and nightlife. After dark, things go pretty quiet, pretty dark, pretty fast. And so it's really like that till the next day.
That being said, did you get Johnny the taxi guy to take you down to Moshi for El Rancho restaurant, or the Kili Wonders Hotel that has that rooftop pub?
Yeah, I did manage to get down the town as well. So halfway through my stint, I did go down. Actually, I went down with the doctors, and we had a bit of a time off for a few hours, which was brilliant. So, again, it comes back to the point is if you are willing and open and being there to work and show the value of what you can bring there, you'll be welcomed. And not only that, you'll then be invited out with the doctors who will look after you as well. So I was very fortunate that they took me under their wing in a social sense as well, right? And took me out to some of the places. So happy I got a little social time with them as well, which was great. So you're not on your own. It does feel like it on the first few days, but it quickly settles and you quickly know and have some jokes going on with the team around you and start building up a good rapport with the team. So, that's what comes from, dedicating yourself to the team and being available and showing you're willing to work. And if you do that, the doors will open for you.
And that is a profound bit of knowledge to learn if you want to get into austere medicine. It's community. It's the people around you. It's building relationships that's going to make you a better medic.
I think that, this is the difference between when you're up in Kibosho versus KCMC. KCMC is such a high volume of patients, and you're there to learn, and you're there to learn really the basic techniques of what you need to do with all these patients that when I went there, I remember I didn't know. I'd never done half of the techniques that I needed to do. And then, of course, on day one, you do it 10 times. And so by the end of the first day, like, wow, I'd never even expected to do this. So KCMC, you're there for the learning opportunity because you have the volume of patients and all the training staff around you and a very collaborative training environment. Whereas in Kibosho, yes, you have the teamwork dynamic around you, but don't expect there to be, teaching staff around you in the same sense because they don't have the time. There's one doctor covering multiple wards, including the EMD. There's one nurse who is covering the whole of 10 patients in the EMD, and that's it. So you don't it's not a learning environment per se. It is more of a hands-on experience, and you're learning other skills just like that: the teamwork dynamic, the ability to be independent and work autonomously. Right, that's the skills that you're learning in that placement.
And that's the beauty of having Kibosho and KCMC in one, well, not one location, but definitely in the same side of the mountain. And at KCMC, you're getting the basics. It's a teaching hospital. There's 60 expat medical students coming from around the world to get their medical placement. And our lads are there as well. Ladies are there as well. And it's a great place for a teaching environment. But that's not Kibosho. Kibosho is, as you said, it's for the solo standalone practitioner who happens to have the ability to have a doc there to ask questions. And that's a fantastic, I think it's one of the best places in the planet to learn for the SOF medic, for the remote medic, to learn to practice on their own.
Yeah, exactly. And of course, as a college, we focus on the hard skills as well, of things that you must do and must learn. And so you're not going to get the volume that you need in Kibosho. So KCMC, absolutely, for those first years. And I'm very happy that I did it in this order, KCMC first. I mean, it doesn't work any other way, but it makes a lot of sense in this order. So, coming from experience, absolutely, KCMC first, and then you move on to a placement like this at Kibosho, just up the mountain. Only 14 kilometers up, but it feels like another world.
You know what I like? It's cooler. So being Irish and being down at KCMC, I've been there every month of the year. Is bloody hot, and as soon as you go up, it's magical. It's you go up the mountain, it's cooling down a bit. You get the view of 120 kilometers off in the distance, and then the church. Tell us about the church.
Yes, the church. So the church is very historic. The Catholic Church is there. It's a beautiful brick church, beautiful stained glass windows in there. I was actually invited to go for the Mass on one of the last days, and it was a celebration or a commemoration for AIDS Awareness Day. And so we did some events around the hospital, around the center with the doctors to commemorate that. We heard from survivors or patients, and there was a service with the music and everything that goes. So it's quite an experience. If you do get invited to attend with the sisters, absolutely, I jumped at the chance and went for one morning there.
Nice. I remember my first trip up, and we're looking at the hospital, and then Dr. John Matero, the CEO, is like, "Well, you got to come to look at this." So we walked out the front gate, and like, okay, where are we going? Where are we going? And you turn this corner to the right, and this church looks like it was nicked from Ireland. Like you could pick up this church and put it in any rural parts of my country, and it would blend in. The stones were brought by the Germans in 1840 up the hill, and they made this stone church that can hold 120 people. It's mental that they put this up in the middle of nowhere. It's beautiful.
Yeah, and that, of course, that's why the hospital is there at the side, and why it's still in location, and why it will never move. So as difficult it is to get up the hill and up the dirt track, that is the Kibosho world. And of course, there's a school next to it as well, and a community of 20,000 around. So as difficult as life is part of the way up the mountain in the rainforest zone there, then that's their life, and a fantastic community that is just around that environment. Very different to KCMC, just down the road.
And what about the language problem? Is everyone speaking English?
Not so much as KCMC. Of course, yes, for everyone, all of the staff and all of the doctors and nurses, no problem at all. The beauty here is you've got time with patients. There's not so much of a rush with the patients that in some cases in KCMC is so busy you don't get to hear the whole story, because the history taking is done in Swahili. You don't know, and then of course the treatments and the consideration of payment and so on, the conversation with the family, that's all happening in Swahili. And then if you're lucky afterwards, you have a moment where you can ask, can you just give me the summary? In Kibosho, you have more time on your side. So history taking takes a bit longer, but you have the time to translate and you can work with the nurse and the patient to understand a little bit more of the history. So time is on your side, and for that, it's easier to get the understanding, even if you have to translate along the way. So history taking was much more easier in that kind of more slower environment. And even if you didn't get it the first time, then over the next couple of days, when that patient is admitted and still being monitored in a prolonged sense in the EMD, you've still got that opportunity as well to ask questions and go back and revisit the history.
So, of all the trips you've done, how much of the Swahili language do you have now?
Oh, still very basic. I think I picked up the first time KCMC, and I tried again this time. Yeah, it's I'm still getting pushed by, I still get the jokes by all the nurses and the docs on how bad my Swahili is. Yeah, it's much to be desired, but working on it.
So, Simon, what advice do you have for the SF medic, the austere medic, the city-based paramedic, anyone who would be interested in this? What would you have to tell them?
I think there's a few things. First is the key skills. So the fundamental skills, be confident in all of your fundamental skills, which of course you will address in the first years of training anyway. So know those skills, and that includes everything that the nurses do on the ward, NG tubes, catheters, and of course be very, how do you say, good quality and efficient with your use of equipment, and that just comes with practice and skill, right? So you're still in a resource constrained environment, so nobody wants to see you work your way through 5 cannulas before you secure your line, right? So try as your best to get your skill proficiency level up, right? So that's number one. With that, you'll then be, welcome to just take on the patients and stabilize them as and when they come in, and that is a skill, especially in the emergency environment. There in the emergency room, that's where you show your value as a paramedic, to help in that situation, right? And with that, refresh your skills on resuscitation as well. I mean, that's obvious as a paramedic, but yes, that's where you add your skill, where you will lead the team if need be, for those interventions and that situation. So those are the number one is key skills. Second is the improvisation, right? This is not MacGyver style like I was talking about. It's in no way do you change medications, do you affect any of the medical equipment, any of that. It is in the ability to move the patient around and to reposition the patient and to hang a line from here, or try to find a way by sharing the electricity between 2 oxygen concentrators, and what if one goes wrong, and how we're going to swap that out. So you need to be a bit open-minded and a bit of a problem solver in terms of those hard material things that happen every single day, every single shift, right? Just to keep the lights on and keep the environment running smoothly. Don't expect that there's a mechanic there, or an assistant or a technician who's going to help you with all of those pieces. And there's definitely no other equipment to go and scurry from. So you really have to try and make do with what you have and share it around. So be resource clever, but be open-minded about the solution. Of course, keep it safe, keep it in keeping with what is being done in the environment, and at all times you're looking after the patient care anyway. So that's the second thing, right? Just being resilient and open-minded to be a bit more, how would you say, utilize the resources that you have available. And then third is the team aspect. So you will succeed in this placement when you walk in with a big smile on your face and you welcome them into your world just as much as they're welcoming you into theirs. So, and that applies to the doctors and the nurses and every medical attendant who is working there. They have very specific levels of staff, in both in KCMC and Kibosho, but none of that really matters in the team. It's all one team in the department. and beyond in the other wards as well, the other parts of the hospital. So the more that you muck in as one team and you come across as a team maker and a team player, you'll be rewarded 10 times back, right? In the care that you're allowed to give, and in the social environment that you'll be part of, and that will just, you'll walk away from that placement with both new friends, new learning, and a whole new world opened up, right? Even if, like me, you've been there I've probably been in Tanzania 8 times over the years, and 3 of those times in this environment. So even now, I walk away with new friends, new experiences, and I love it. So it's an open mind. Keep an open mind, and you will be rewarded.
So 3 very good points, and all of them applicable for the austere medic, for the remote medic wanting to learn to provide care in austere environments. And you've nailed it. Well done. Yeah, thanks for giving us your feedback on Kibosho, and I look forward to seeing you graduate from the BSc and seeing where you go from there. But Simon, you have been a fantastic student, and I appreciate your input for your time at Tanzania.
Thank you. I'm looking forward to get back to Kibosho as well, and I do want to try and get another stint in there before I finish my placement. So happy to go back there and see the team again.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.